Hello and welcome. The number of COVID-19 cases are, as we all know, easing off across India now. But in some parts, including in rural India, perhaps the numbers are not falling as rapidly as they are in urban India. The numbers themselves, as you know, are sometimes a little under some cloud, particularly in areas where maybe the quality of reporting is not as much. But a Center of Science and Environment report a few days ago said that the number of rural districts or the rural districts had seen almost 52% of COVID deaths. Now, this is, of course, based on a sample. And they also said that 53% of new cases in May were from rural districts. They also pointed out that community health centers in rural districts needed 76% more doctors, 56% more radiographers, and 35% more lab techs. Now, this lab technologists. So this is obviously to just give an illustration of the nature of problem in rural India to the extent that we can even measure it. So to understand what we can do and in rural India in a very broad sense, from a hard and soft infrastructure point of view, as well as the kind of responses that we can work on, I'm joined by two people who've been working on and responding to some of these challenges. Dr. Rajni Bhatt, consultant pulmonologist from Bangalore, who is also a postgraduate of the Albert Einstein College of Medicine and ABIM certified in pulmonary diseases and critical care medicine. Dr. Pavitra Mohan, co-founder of Basic Healthcare Services based out of Udaipur, has a MD from Safdarjung Hospital in Delhi University and a master's in public health from the School of Public Health at the University of North Carolina. And has worked extensively in community-based primary healthcare and nutrition. Thank you both for joining me. Dr. Mohan, let me begin with you. So what I'm trying to understand is, as you look back, particularly the last 2 months of wave 2, what is it that you can tell us about the behavior of the virus and the behavior of the people who've tried to respond to this virus, particularly in rural India in general and the areas that you're working in?
So, I think one thing is clear, that the virus has spread much more rapidly in this wave as compared to the past wave. And there has been no divides between urban and rural, or rural and deep rural, or deep rural and tribal. The infection has spread in the deepest of the areas, which was not the case in the last time. So in some ways, actually, it is the first wave for the deep rural areas and tribal areas, right? I mean, last year, there was no wave for them. It was largely restricted to urban areas, and some spread happened when the migrants started returning after a month or so, when they were allowed to come back. There was a slight surge, but it was not really a wave. It was probably a small ripple. But for them, it is actually the first time that it's a full-blown wave, and it has not followed any boundaries of urban, rural, or rural and tribal. So the virus has spread much more and much deeper this time, right. And the way people have responded to it has been, a lot of fear. It has been guided by a lot of fear and also a lot of mistrust of the public systems, right? And I think this mistrust led to a situation where people were, the combination of the fear and mistrust meant that people stayed indoors. They would not go out to access healthcare, and especially not from the public systems at all. And they would seek care from whatever was available closer by, but avoiding the public systems in general. This is the scene in areas that we work in, and I've heard similar things from other people working in similar rural and tribal areas elsewhere. The mistrust had its origin. I think one is that in general, there has been a mistrust of the public systems for a long time in rural areas, and partly guided by the fact that the services have not been responsive, and therefore they've progressively, especially for curative services, have kind of shunned away gradually. Wherever there are strong public systems, so that's not the case in the entire area, but wherever there are strong public systems, that is not the case. There is a greater trust, and that continued. But in general, that being the case, this was further accentuated by the fact that last year, when people, especially the migrants to the cities, when they were returning, they were isolated, they were forcefully quarantined, and that led to a fear of the government systems in general, and of the public health systems in particular, and of the disease. That if you say that you have a disease, or if you are found to have a disease, then you'll be shifted away. This was, of course, fueled by the social media news and reports of people dying, and all kinds of myths and misconceptions being also propagated through the social media. But its root lied in the distrust and the fear
Right.
of being isolated and quarantined. Also, this time when before the second wave began, there was vaccination, which was where several coercive vaccination when it started in January and February. In the beginning, there were coercion used to promote vaccination amongst those who initially had vaccine hesitancy, which is not uncommon when you're introducing a new vaccine, especially for the adults. That vaccine hesitancy is common in all populations, and that mistrust deepened because if you're coerced and said that if you don't take a vaccine, then your name would be removed from the elderly age pension or from the PDS, and that distrust led to a situation where people are fueled by and coupled with the fear that they stayed indoors. They feared telling anything about the disease or going out to a public health system, which in any case they had limited access to
Right.
or response to. Yeah, and
So
that kind of led to quite a bit of delay in care seeking or absence of care seeking. A lot of people continued to be indoors, and even when deaths happened or they had started slipping, they would still would want to stay where they are rather than going to a government hospital in a city which is far off. There are of course structural issues which were always there of distances, of not enough money to reach a large hospital in a distance. But it was kind of added on by the fear and the distress.
Right, and you're saying that these are people who could have gone to a public health system and they may have been placed in the public health system, which is a bed or maybe better still oxygen if the person needed it, and yet these people did not go.
So there were two. That's right. So there are two scenarios here. One is people who had mild infections who did not really require to go anywhere, but they required support, advice, and medication to manage it at the household level or in a setting where they could isolate themselves. So even accessing advice and accessing support for home care is something that they desisted because of the fear of being found out that they're COVID positive and therefore being removed or isolated or separated from the family, etc. Right. So even when there were government health workers, frontline workers like ANMs or ASHAs would visit the homes, they would withdraw and not disclose and would not want to even receive the medication or the advice that was being given. Yeah, and on the second scenario being where when you're moderately or severely ill and you start slipping, and when one could reach the hospital, but the whole fear of going to a hospital was huge, and therefore one of the reasons I was in a debate where they were saying that why is it that you did not see the pictures of people in a hospital in rural areas asking for beds or oxygen, etc. The reason is that they did not reach the hospitals and often would become severely ill, either recover or die at home.
Right. Okay. And I'm going to come back on that the vaccine angle as well in a moment. Dr. Bhatt, tell us about your experiences in this context and also what you're working on and preparing this response in the form of this toolkit or resources across India.
I think Dr. Pavitra Mohan has raised all the relevant points that come up in the challenges that we face in implementing, science-based protocols which are useful for the rural health setup. There are so many challenges in terms of lack of infrastructure, lack of manpower, lack of training, and to add to that all is the problem of mistrust and misinformation, which has been a huge problem, not just in the rural areas, but also in the urban areas. We've seen the rumor mongering and myths and fallacies spreading much faster than the solid scientific evidence that needs to be propagated better. In order to counter that, there's a group of us who've come together to form a community science alliance. It's called the Swasth Community Science Alliance, and it was born as an organic effort of clinicians, practitioners on the ground, along with physicians, scientists, health economists, people with experience in public health or global health, and looking to address these challenges of how does one help in implementation of the best practices in the rural areas where it is most useful. One of the challenges is that when we come up with evidence-based medicine practices, that's sometimes formulated in areas which have access to the best facilities. So you say you put a cutoff point of a saturation level, which is that, you can seek hospital attention at a certain level, one has to keep in mind that there's a lag time, in the rural areas where it might take 6 to 8 hours to reach that medical attention. So one has to adapt these evidence-based guidelines and protocols to take into account the kind of time constraints that we work with in rural areas, and also the kind of instructions that are available. Is it something that's a medium of instruction that's easily accessible to the ASHA and ANM workers who are embedded in the community, who the people trust? What are the facilities available? What we've seen in the response to the rising numbers in COVID in the rural areas we've seen a wonderful, surge of support from community, from corporates, from nonprofits, from charitable organizations coming to the aid of government health services by providing resources which are material resources. But you mentioned that we also lack manpower, we also lack training. So to that end, what we're looking to do is to provide a suite of offerings, toolkits that are easy to understand and access for people in the rural healthcare services. And this is an alliance in the truest sense, because we are guided by serious, experienced practitioners on the ground like Dr. Pavitra Mohan. It's only based on the feedback that we get from them of the challenges on the ground that we are able to formulate certain training modules which can potentially help us to counter these problems.
Right. And can you give us some illustrations on what are the key areas that you're focusing on in terms of communication? And secondly, does this apply uniformly across India or most parts of India? Or do you see, I'm not talking about language, but do you see other things that you have to adapt to?
I think there's definitely some parts of it which are universal and adaptable to all parts of India. In the conversations that we've had with people who are practicing on the ground, be it from Maharashtra or from Nagaland or from Tamil Nadu or Karnataka, some challenges remain the same across the board. Some practices remain the same across the board. And our focus has always been on trying to make sure that we eliminate any harmful practices. One of the challenges has been that there's been a lot of different medications and polypharmacy that's been thrown at the disease. What we've learned over time, over 1 year, is that the old gold standard practices, the best supportive practices for any viral illness, still hold true. And that's something that the system is ready to deal with. It's just about removing the misinformation, removing the myths, and enforcing the part that we can really do and implement well with the people that we have on the ground. So if I look at it in terms of the challenges that are there, they are universal. Some things are local. Some degrees of trust issues will be local according to community practices. But that's where the partners on the ground come in and help us with that. We have toolkits that will help us for providing home monitoring services. So an ASHA worker or a community health volunteer should be able to help the families and in the communities be aware of what to watch out for, and build the trust in order to make sure that the monitoring continues and is relayed to the medical officer whom they report to. The idea being that this is a disease where the majority of patients are asymptomatic or mild, or even at the early time of when their oxygen saturation is dropping and in moderate illness. Even if the district hospitals are overloaded, there is a potential for having COVID treatment facilities that can provide oxygen and the basic medications and still allow for a much better outcome for patients. Right. It's really a sad state of affairs that we're seeing patients not seeking help because of fear and mistrust, as Dr. Pavitra Mohan pointed out. And that's the part that we want to address, that there is a large chunk of patients that we can help just by bridging that gap.
So tell me one thing that you have seen in your research or conversations with doctors across the country, or one finding which surprised you and to which, of course, your toolkit is or resources are responding to.
So one of the things that surprised us is the fact that a lot of people think that complicated medications and things are essential. And we realized that it's really a lot. It's really about sticking to the basics. It's about good monitoring of vitals. It's about educating people about simple preventive practices that they can do. Awareness with masking, awareness with early identification of symptoms, taking away the stigma and the fear associated with the disease, using symptom control with simple things like paracetamol for fever, simple practices like prone positioning for improving oxygen. These are the things that really are valuable. We know that it's only in certain patients whose oxygen levels is low that you need steroids. So making sure that that kind of information is available. When you tell people that you don't need these expensive medications, that's a very small minority of patients who need it. That's the part. So one of the questions that comes up is, oh, we don't need to give this, we don't need to give that. Absolutely. The part that's been really important in our work has been to propagate the first do no harm practices, the do not prescribe these drugs. And it's really been heartening to see. It's wonderful that the DGH's recommendations that have come out recently are very supportive of the best practices that have stood the test of time over decades.
Okay, and I'll come back to that in a moment as well. Dr. Mohan, you were saying that one of the reasons you're seeing a pushback towards the entire health system is the attempt to vaccinate. Now, is the attempt or the coercion in vaccination. Now, I'm assuming some of this is legacy, but tell us how it's playing out right now and how it is perhaps affecting people more than benefiting them.
So, as I said, that there has been a distrust, and that led to a situation where people would not accept vaccination, thinking that it will harm them. It is meant to harm them. It's not only the fear of the side effects; it's the fear that they are being proactively harmed, and that's that's where one needs to start working on. And what we've seen is that while working with the communities and with the families and with honest communication about the vaccine, its origin, its value, some of that does start melting off. The other problem, and which we have to understand, is different from urban India. It was both in case of treatment and in vaccination. And the way it is playing out is that we have to remove all. There are huge barriers for people in rural areas to access any service. Right? That can be the barrier of distance. That can be the barrier of denial when you reach there. It can be the barrier of the cost that it incurs. And therefore, for example, a simple example is that if you're bothered about vaccine wastage in a rural area where population density is small, and very few people want to now just start getting themselves vaccinated out of, say, 100, maybe a few want to get vaccinated. At that point of time, denial of vaccination because of the fear of wastage is something that is counterproductive. Secondly, at the moment, there are barriers of age. There are different ways in which people of 18 to 45 years or 45 plus would get vaccinated. And therefore, there are barriers that because you are younger or you are older, you may not get vaccine on a certain date. Third could be a barrier of distance where the vaccine is available only at a primary health center or in a remotely located sub-center, and the time taken and would be. So I think removing some of those barriers, making it freely available to everyone, not denying being the first principle, then the wastage or the efficiency of the operations is extremely critical to.
Right. And when you said coercion, for instance, this is just, I'm assuming it's only a threat, because no one I know or have heard of is actually saying that we will dilute you from some roles or take away some public distribution system benefits if you don't vaccinate.
Right. So yeah, so these are threats. But the problem is that the coercion becomes the major way in which you can implement anything with the communities where there is an initial resistance. As recent as a few days ago, there are now cities in some other states that I know of where they said that if you don't get vaccinated, then you can't open a shop in a given market. These are official orders, right? So when coercion becomes the primary means, then there is a pushback further, because you say that if it was for my benefit, then let me decide it, right?
Right.
And so while it is a threat, it is also perceived as something that's not for you benefit. It is something that somebody else wants you to get done.
Right. So now several months have passed. I mean, we've been vaccinating for almost 6 months now, give or take. And I'm sure Rajasthan, which is where you are and which has seen a relatively higher proportion of vaccinations, should also be seeing the benefit of that. That people who have been vaccinated, even maybe coerced into doing it, perhaps can see that they are either not getting infected or not getting infected seriously, or is it that they are not able to perceive that?
So, that perception is slow to come. And, for example, one is that if somebody has been vaccinated earlier, there are a lot of examples where the health workers say that we have been vaccinated. But then the pushback is that, okay, you received a different vaccine. And what we are receiving is a different one. The other is the population density issue. So the benefits of vaccination, even childhood vaccination, is not easy to see. Because, if you vaccinate 1,000 people and if 10 were to develop the infection and you protect 5, in a given village, you have actually prevented 5 infections, which is not very visible in the short term. And it does require much longer term, but that is the kind of honest communication that one needs to do. We have been successful in several cases where this honest communication was allowed and other barriers were removed, which does lead to an improvement in acceptance. But you have to speak that language and not the language of it being for the public good or for some kind of intangible benefit. People
Right.
do understand that if that's been our experience in several villages where we work.
Right. Okay. So, Dr. Bhatt, can I, what's the scale of what you're rolling out here, and how is it going to be distributed, and how are you going to measure how it's working, and and what's your feedback mechanism going to be like?
Well, at the moment, we're very happily surprised with the scale at which it's rolling out and the kind of interest that we've received from practitioners on the ground, from the community. We've had a tremendous response, whether it is from experienced organizations which have been involved in community health and primary health in rural areas for decades, as well as CSRs which are partnering with certain aspirational districts looking to roll out these programs, and as well as certain organizations which are very closely enmeshed with government health services. The scale, it's the conversations that we're having, the scale goes anywhere between 1,000 to 1,800 ASHA workers to, in some situations where we're looking at community health volunteers, scaling up to as many as in the tens of thousands. The idea being that if we can empower people with the right knowledge and the right information, these people can become change agents within their own communities, as long as they have the right information. So it's about distilling the scientific information and making it simple and easy to absorb, as well as to share with other people. To Dr. Pavitra Mohan's point, the success of an attempt like this will be in the fact that people will think it wasn't needed at all. It's when things are not dramatically bad and it seems like things are okay, that's when we know that we've really done a good job. But that's not enough. We would like to measure what's happening. So we have, as part of our toolkit, there's also data monitoring and evaluation that's built into it. We've tried to keep these documents very simple, so it's part of the healthcare workers' daily routine process of being able to document that. We've also taken into account the fact that there may be limited literacy in some of the community health volunteers and workers. So a simple thing like a photograph of a pulse oximeter on a finger is something that can be taken and sent via a telephone WhatsApp message. And that's something that we could capture to be able to monitor that. The goal is that with the academic institutions partnering, we have Professor Manoj Mohanan at Duke University and his team looking into this to be able to give us rather quick turnarounds on what are the interventions that are working and what we might need to tweak. The other part that's really useful is going to be the feedback from the partners on the ground. So the doctors and the medical officers who, along with the ASHA A&M workers and their medical coordinators, will be giving us feedback. That's the hope. That feedback will help us to tweak the program as needed as we go along.
Right. Now, we do have new medical protocols or medicine protocols for finally. But tell us, this is, I'm pretty sure, an urban and a rural problem. How do you see this rolling out? And do you see this having an impact now at this point? Because, even while guidelines come and protocols come, it may not be transmitted effectively enough, or it may not be received effectively enough.
That challenge always remains, I think, with all guidelines and recommendations, because but when we have guidelines that are evidence-backed, as well as policy-backed. So you have academic institutions like CMC Vellore, you have government institutions like the DGHS, all of them coming on the same page and saying, this is what the evidence shows, this is what is best practices after 1 year of learning about this new illness. That gives us greater strength in the voice that we take to the medical practitioners on the ground. So if you are a doctor or you are a nurse who's practicing in a rural setup and someone says that, oh, but why aren't you giving me XYZ drug? You know, you have the knowledge to back you to say, you know what, that's potentially harmful. That's the idea, that we want to try and take the message of first do no harm. We know that injudicious use of antibiotics, injudicious use of steroids is harmful to patients. I think we have all suffered from the fact that there are certain drugs which were considered, it can't really harm us that much. But that really does not, as much as we try to take, as much as we try to say that, oh, it's not going to harm us, it's taking away from a potentially beneficial practice that one might be able to provide. So I would much rather, instead of prescribing drugs which are not so useful, have the community health worker focus on the importance of messaging about masking and vaccination. As Dr. Pavitra Mohan said, that's where we need to focus our energies more. It's about the preventive strategies, and there's plenty of evidence and research coming out of neighboring countries. For example, Professor Mushfiq Mubarak's work from Bangladesh, which can inform our practices about how we build bridges to overcome that mistrust that exists in rural communities about these about the use of vaccines and better masking.
Yeah. So the Bangladesh study is about masking and how I mean adopting a certain community or a village, and then seeing how people wear masks and then incentivizing them to wear masks. Am I right?
Absolutely. It's about making sure that people, so it's not just enough that we wear masks, but we use it appropriately. I think the messaging is really important. As Dr. Pavitra Mohan was saying, when you try to make it about, when you make it punitive, that's not quite the same thing as incentivizing it as good for the community and for yourself. Really, in the end, we care about the safety of our own families, and our messaging has to resonate with that community. I think that's a very important piece of for prevention.
Right. Last set of questions. Dr. Mohan, let me come back to you. So if you were to, as we look ahead, potentially to a third wave, what is it that you think, if I were to ask you in, like 1 or 2 bullet points, that we should be now gearing up for? So we've talked a little bit about the soft side. Is there something on the hard side that we could conceivably do in the near term to be ready for a potential third wave and be ready in general?
So I think as far as the, how do we really prepare for something that seems inevitable, but what form will it take is what we can't really predict at this point of time. And I think first thing is, an important thing is not to have a sense of complacency at this point of time, which seems to be setting in many quarters. From a rural healthcare perspective, I think keeping, in fact, many of the things that we needed to do were barely coming together towards the end of the second wave, and not surprisingly so, because our public health systems in rural areas have not been traditionally geared to managing emergencies. Even in normal times, even minor emergencies, this was, of course, a huge emergency. And the capacity of the public health facilities to manage and public health services to manage such emergencies has been limited. And I think immediately we do need to ramp that up. Using the COVID kind of experience of the second wave, which is, for example, if we talk of COVID, to really ensure that we have the availability to manage respiratory emergencies like COVID and others. Oxygen availability is one part of it, but having the right set of knowledge, skills, protocols in place, referral systems in place, the right skills in place is so important. And if we don't do it now, the third wave, we would be doing the similar, goof up as we did in the second wave in many parts. And that has been, in second wave, it was excusable to some extent, especially for rural areas, because nobody really expected it till very late. And traditionally, we do not have strong public health facilities in rural areas. But third wave would be inexcusable. So I think ramping up in the skills, the standardized protocols, the referral systems, and people in rural areas would be absolutely critical. Surveillance would be really critical to ensure that we detect it in reasonable time. We did again that up overall, that we did not pick up the emergence of the second wave in time. And finally, as I said, that just not be complacent and prepare for the worst would be really important from a public health point of view. We really also, I think one of the things we did end up doing by the end of the second wave was in many places to at least have some places where oxygen is available in rural areas within a 30, 40, 50 kilometers. And in absence of referral, that still is too far. And we do need to now, equip our primary health centers and community health centers closer to where people live to be able to manage an emergency and an epidemic like COVID and others. And I think we have a short window. We have about 5 to 6 months at the most for preparing and really putting all of it on the ground.
Right. Dr. Bhatt, last question to you. So if I were to extend that question a little bit and say, how do we use the learnings and to the extent we can, and look at beyond COVID itself? And if some of this could be applied so that we can strengthen our rural healthcare system. I mean, we could do that for urban as well, but we're talking about rural today. And to what extent can we do that by using all of this?
I think one way of using what has come out of the crisis that COVID has presented to the country over the last 1 year is the fact that health has become dominant in the national consciousness, whether it's in terms of the kind of response that one gets from communities in small urban clusters or in rural areas. People are conscious about the need to pay attention to their health. It is part of almost daily conversation now. The fact that there are a lot of initiatives that have taken off from the part of the government, which has always been there, but also in terms of non-profits, corporate social responsibility, all of that rising together to build a supportive ecosystem to support better health for most people. And the part that I find really promising is that it's not just physical health. There has been a greater conversation about mental health. There's been a greater conversation about palliative care. All of these aspects of primary health or preventive health, which were ignored or did not receive the attention that was due to them for the longest time, is now being spoken about in mainstream. When was the last time that we had these kinds of discussions on national television about every aspect of health and well-being, not just disease or when something goes wrong in the public health system, but we're also talking about the preventive and the maintenance aspect of health. So I think that's one of the things that's come about. The other part that I think the conversations that we're having today and what we hope to continue is with the Swasth Community Science Alliance, we're building what's called the community of practice. And the idea is to have experts like Dr. Pavitra Mohan, somebody like Arman, which is, maternal and child health, coming together, and a whole lot of people, whoever is interested, coming in to join in that conversation, connecting different parts of the country, different initiatives and efforts from across the country to learn from this community of practice and take those best practices back to their communities that they're serving. So that, I think, is going to be the future. Now, while we're using that to address the challenge of COVID, this is something that can go on to every other potential health crisis that we have to solve, whether it's non-communicable diseases or new waves of infectious diseases or epidemics that may come along.
Right. That's an encouraging note to end on. Dr. Rajneet Bhatt, Dr. Pavitra Mohan, thank you both for joining me, and I do hope to keep coming back to you to hear and benefit from your insights. Thank you very much.
Thank you.
Thank you. Thanks.